enthusiastic, I hope you're as enthusiastic as we are to see this type of technology come to fruition. As we say a lot around here, it is not about being the best doctor in the world any longer. It's about being the best doctor for the world, for your patients, and for your local community. And something that Dr. Min said was, I think that resonates with everybody is this is technology that is now ready. Like, it's being used. It has gone through the vetting and clinical trial processes, and this is testing how it should be and could be, and it currently is, and that's the enthusiastic part here, is and can be started to be useful for you and for your patients today. So we have a few questions that have come in for you, Jim, and let's go ahead and keep the screen up there in case people have further questions for you and your team. So one of the first questions that we have here is, how do I identify as a physician the appropriate Cleerly patient, and what is some of the criteria that I should be looking for?
I think that's really a great question. We've tackled this question in a number of different ways. Like, there was a group that we were talking to who wanted to do the Cleerly analysis for a great deal a high number of people. And so we talked about, like, well, what should the criteria be? And then they said, well, maybe we should do a pilot where we do it based on risk factors or diabetes or hypertension. But it turns out, like, that's the problem, right? Is that 70% of the people who are younger who come in with their first heart attacks don't have those things. And so what we've done, at least what we haven't recommended anything, but what has been decided by the physicians that we work with is that they usually use a cutoff range of 45 years of age or 50 years of age. And then what we know is that coronary heart disease events, heart attacks in women, tend to trail about 10 years longer than men. But what the reason that is if you look at the scientific publications, what women do is they have more positive remodeling. That means they form the plaque and then they start to push it outwards in order to maintain the integrity of the lumen where the blood flows. So they don't feel symptoms because their body's very good at sort of pushing all of that plaque outwards, and hence they never limit the blood flow. They never get any angina, but that doesn't mean that they don't have disease. And so it's the fundamental premise that this is a silent killer in the majority. And so, at least, we don't have a specific age cutoff, but like what the doctors that we work with have done, some have adopted 45 years of age and others have adopted 50.
One of the next questions is a pretty simple one. Will a version of these slides be available for download or for review?
Yes.
Great. All right. Another question that came in is the Cleerly analysis covered by insurance? And the second part of that is, I offer my patients a range of services. Some I submit for reimbursement, some I do not. Where does Cleerly fall?
That's a very good question. So, at present, in general, the insurance providers and the healthcare system overall, right, like, allows us to evaluate late stage symptomatic disease, but not earlier stage asymptomatic disease, where we can really make a big dent in terms of preventing disease progression and heart attacks. Our company has a family of CPT codes that were issued by the American Medical Association that can be billed for, but to be very clear, like, there is not a reimbursement that's associated with that. So right now it is an out-of-pocket expense for the patient.
Great. And a couple of questions related to price. If you have questions about price, the cost, those types of things, please email info@cleerlyhealth.com and they'll give you more information about this. That's not a topic that we're going to cover today. But also the next question is related to what website do you go to as well? It's right there, cleerlyhealth.com. Another question that has come in is, I like what you said earlier a few minutes ago, patients come in armed with knowledge before they even arrive in the exam room. And I know that there's a little bit of pushback among so many physicians out there that, don't bring me stuff you printed out from the internet. We can't get through all of your questions at that time inside of kneecap to kneecap in the exam room. But we as patients, I always say I'm not a physician, but I am a patient. And so I do know what it's like to be on the other side of you, on the other side of the exam room. And when we feel heard and when we feel listened to and when we feel like you're answering our questions, that's the heartbeat of the relationship, no pun intended. Jim. But I love that we can come in armed now with a little bit better clinical ammunition to talk to and discuss these concerns that we have with our doctor. And so the question that I think boils down to that people are asking here is, do you offer a service to explain the results to my patients or review the analysis with me beyond what you've put into the reports, especially as I get up to speed on their condition and this research?
Yeah, I think that's a great question. So let me tell you what I think is the problem, and I'll give you sort of ballpark numbers, but I think that there's this three-step sort of 90-90-90 problem. We didn't have the tools to be able to extract all of the data from the images. So on a typical coronary CT angiogram read, we lose about 90% of the wealth of that data as it relates to improved diagnosis and prognosis and whatnot. Then I think that there's this 90% loss of data when it goes from the imaging physician to the clinician in the office, and another 90% of data that's lost from the clinician in going to the patient. So all we did was try to rescue and salvage that data and really present it to people in digestible, comprehensible, and actionable approaches or ways. And so to answer your question directly, Michael, we do offer that type of service. And so what we do is we have an onboarding process where we take physicians through the software, through the report, and explain to them everything that we see, where the buttons are, how they can access all of that data. And then what we do for a temporary period after that is, what we can do is one of two things. We can, for each analysis, we can spend some time with the doctor and then go over each analysis and explain to them how we see, that analysis playing out. Alternatively, if the doctor thinks that it would be beneficial for the patient to be on it, as long as the patient is agreeable, then we could do sort of a virtual visit with the patient and go over the findings as the doctor does it as well. And so that is offered to get the doctors up to speed, and we'll do it as long as the doctor needs us to really do it to feel comfortable with the exam. But there's a lot of data, but I think what the doctors have found is that after they do 2 or 3, they get it, where they're looking for the most important things. And I think that centerpiece really helped them because they really don't have to leave the centerpiece. Certainly, like the primary care physicians that we work with seem to like the software quite a bit. Wow.
Well, and this last question, I think, centers around, and you probably have, I think you have partially answered it. This last question, or I'm sorry, we have 2 questions. This is the second to last one. Do you offer guidance on what I should do with my higher risk patients? For example, are there treatment algorithms on how to use the novel medication or lifestyle interventions to reduce risk?
Yeah, that's an amazingly wonderful question. So, right now we treat in a population-based fashion, right? Rather than a personalized fashion. We use things like cholesterol, and what we see is that, the people, when you compare patients who had heart attacks versus those who didn't, there's an 80% overlap in their cholesterol levels. So it's clearly not the ideal method of figuring out sort of risk and things like that. Michael, I'm sorry, I just forgot what your question was.
So it was related to
treatment algorithm. Yes.
Yes.
And so Cleerly does not specifically advocate for any treatment algorithm, but we have worked very closely with doctors, and the doctors have said, look, we're not going to treat to the surrogate markers anymore. We're going to treat to the actual disease. And so they have spent an enormous amount of time coming up with these sort of very logical treatment algorithms based on lipids, on glucose, on blood pressure, on obesity, and on tobacco cessation. And so we, for any doctor who's interested, we can introduce you to those doctors, or, we can share with you the approach that they're taking as well.
And another question, in case you missed it from earlier, for those listening and watching, is cleerlyhealth.com, Cleerly with 2 E's, as you see there on the screen. info@cleerlyhealth.com. You can learn, that's how do I engage with Cleerly, how do I engage with the software, how do I get to know more for your practice individually. Again, email info@cleerlyhealth.com or visit cleerlyhealth.com. And amazingly insightful website, one of the best that I've seen. And I see a lot of websites, so please go cleerlyhealth.com. Our last question for you is maybe much more of an entrepreneurial question, but also related to Cleerly, related to what you're working on. and what you're passionate about. And, you know, a lot of us want to look at 2020 and put it in the rearview mirror. And as we enter 2021 and we're optimistic about what the future holds, you know, what are you optimistic about related to what you're working on? And a second part of that, and again, I ask this of all my guests or speakers, is, you know, if you were to hang up the shingles today, or give the keys over to the next in line, you know, who you feel is competent to take over your role, and you think, you know, this is exactly why I did this. I've run the race. I've accomplished the goal and the vision. And maybe we're not there yet. Maybe you feel like you're just not personally there. What are you optimistic about, and what's a success story that just drives this passion home for why you do this?
Yeah, I think it's really a great question. Like, you know, it's a very difficult decision personally, just for me to leave my job at Cornell and New York Presbyterian. It was a great job. They were both great institutions. But I made the plunge to go because for two reasons. The first is that we were doing a lot of this sort of AI enabled stuff, machine learning. And what I realized in academics was that we were going to publish a paper, but that algorithm which is superior to our current algorithms, it was never going to make it to a patient to actually help them. So, you know, I thought that this revolution of AI that we're going to experience in medicine is going to be best sort of led outside of academic medical centers rather than within. From a clinical standpoint, like, I also felt that if we could create this care pathway in ways that doctors and patients could really like and enjoy using the platform, that I could make a much bigger dent on sort of preventing, you know, heart attacks and helping support the doctors on a personal level. And so, you know, some of the more fulfilling things in 2020 in this sort of crazy COVID time, we found some very sick people who were completely asymptomatic, and it was really rewarding to be able to find those people. And just to clarify for anybody who's interested in watching this is not a question of who should get a stent or who should get a surgery. This is a question of how do I diagnose early and really implement lifestyle and minimize medical therapy, but treat appropriately to try to prevent heart attacks in patients. So as I look forward, I think that, we've probably got a good 7 to 10 years of ideas that we're still going to continue to roll out over the years. But my greatest optimism is that this could be actually used in patients. We can find those patients who are diseased but don't necessarily know it, and they can get effective treatment and improve their lifestyle in a manner that reduces heart attacks.
Well, and our guest today is Dr. Jim Min of Cleerly. He's the founder and CEO at Cleerly and cleerlyhealth.com for those looking at the screen and wondering how to engage with Cleerly and learn more about it and learn about how to get connected with this. Obviously innovative. I mean, this is one of the most innovative things I've seen in a couple of years, and I'm very, very passionate. I think we're very, very passionate about it. And I think that they see your enthusiasm and your passion for it. And I think that everything that you've presented today is truly going to help the world of medicine, help the world of heart disease. And excuse me, having had family members, pass away of this, and friends as well, this is such an important thing. It really, truly is, Dr. Min, making a dent in the universe, as Steve Jobs says. You're making a dent in the universe. Your team at Cleerly is clearly making a dent in the universe. I like puns. So thank you so much for being a Concierge Medicine Forum speaker this year. We look forward to having you as our guest again and presenting new findings, new research, and new innovation and what you guys are working on as well in this coming year. So thank you again, Dr. Min, for being our guest here.
Great. Thanks so much, Michael. Have a wonderful day.